Dynamics manifests very well when we discuss the mechanisms of drug action. In dynamics, this is where we talk about receptor dynamics, the different types of receptors we have, and how these receptors work. In dynamics, this is where we talk about signaling. When a drug binds to the receptor, what really takes place when a drug interacts with a receptor? I told you yesterday that don't look at a receptor as something tangible that has been put in the body. These receptors are chemicals. They are protein in nature. So they are pure chemicals. So when we talk about a drug interacting with a receptor, a drug is just a chemical interacting with another chemical. The receptors are chemicals, basically. So that is what you need to understand. Don't look at it as something physical which you are going to touch, or a drug comes and then it binds to it. And let me hope that is clear as well. So basically, let's start our discussion today. Our discussion today is not going to be as dynamics is not so wide, though, like kinetics, though it is a bit confusing, so you need to pay close attention. We can even discuss it in 30 minutes and finish it. And today is the day of dynamics. Thank God that most of by maybe two, we should have, or one, we should have cleared this. It is not something that is really wide, but it just needs understanding. It just needs understanding. Okay. There's someone disturbing me here. Okay, let's start. So as you can see here, we are talking about drug actions, interactions, and the mechanisms or modes of drug action. That is basically dynamics. Some drug receptors interactions are highly specific. Some are not really specific. There are those we usually call pharmacological receptors that get involved in quite a number of pharmacological interactions. But people always tend to confuse what we call pharmacological receptors and physiological receptors. Yet there is no difference. Receptors are usually found in the body. And as I've told you, receptors are protein in nature. So when someone talks about pharmacological receptor, just know they are still talking about those. There are no other receptors that have been introduced in the body that are specific to drugs. It is the normal receptors where the endogenous compounds of the body work. The endogenous compounds are the chemicals which we produce in our bodies, like the hormones, the neurotransmitters, and the like. Where they bind to is where our drugs usually bind. So some drug receptor interactions are highly specific, as we are saying, and some are not specific. Some are going to be binding to basically those receptors, the physiological receptors or the pharmacological receptors, while others you might not find receptors getting involved. There are some drug interactions that usually work when there's no receptor that gets involved. I'll give you an example. Take an example of an antacid. You've taken an antacid, aluminium hydroxide or magnesium hydroxide. These are some of the antacids which are sold all over the market. When you take in that antacid, it goes into your gastrium, the stomach, and it neutralizes hydrochloric acid, which it finds in the stomach by reacting with it. You can see now there is no receptor involved, but there is some drug action. It reacts with the hydrochloric acid and it neutralizes it. And the acidity, the hyperacidity that has been there is removed from the gastrium. Let me hope I'm clear. That's why we are saying some drug interactions tend to be specific, whereby they tend to work on the receptors themselves. They peak even at receptor level. They don't just bind to whichever receptor they find, but they are specific to certain receptors. Yet others are not specific, they are non-specific. They can bind to quite a number of, they can do quite a number of other interactions which are not even receptors. And other examples of specificity can also be with a drug binding to maybe like, I'll give an example of beta and alpha receptors. We find we have drugs that bind to both alpha and beta receptors, or beta 1 and beta 2. Such a drug is not specific, yet you might find one that selectively binds to a beta 2 receptor, meaning that it is highly specific. So when we say drug interactions are highly specific and some are not highly specific, that is basically what we are talking about. These protein targets, the receptors are protein targets. You remember make sure you remember these. Yeah. These protein targets, the protein targets for drug action on mammalian cell can be broadly classified into these four. So receptors are broadly classified into these four. We have the receptors, we have the ion channels, we have the enzymes, we also have the molecular, the carrier molecules. Here, when we talk about protein targets, in most cases, we are referring to receptors. When we talk about protein targets, we are, in most cases, referring to receptors. That's why we say receptors are protein. in nature. So let's look at receptors specifically. They are protein structures present on mammalian cells within the cells. And as you can see, receptors are the sensing elements in the chemical or communication system. They are the sensing elements. So they coordinate the functions of all the different cells in the body. And they are chemical messengers that usually bind to them in the body, like hormones and neurotransmitters, as well as other mediators like the autocoids, like histamines, like bladekinins, and other autocoids. We've seen serotonin binding to it, name it, those are referred to as autocoids. On that, that interaction we normally see them working as either agonist or antagonists. We normally see them working as agonists or antagonists. Okay, let me hope we understand this as well. Drugs which act via receptors usually act at low concentration. Yes, they usually act at low concentration. You don't need a lot of it to see the effect. Sometimes they tend to show structural activity relationships, which we normally abbreviate as SAR. So small modifications to functional group or the air stereochemistry or molecular shape can significantly impact the binding affinity. That's why even at the allosteric site on a receptor, allosteric sites, if you remember your receptor very well. The allosteric, when a drug binds to another site other than the main site of action, the allosteric site, you can find that there's a conformational change that can still happen. There's a conformational change that can still happen. Let me hope that is clear as well. So there is that structure activity relationship that usually happen when a receptor binds, when a drug binds to a receptor. And modification in their functional group or stereochemistry or their molecular shape can bring a lot of changes as far as the binding of that drug to the receptor is concerned and the pharmacological activity. There are quite a number of drugs that usually, endogenous compounds and drugs that usually bind to receptors. And we shall see them as we go deep into our systemic pharmacology. But what you see there are some of the examples, the common examples of some of these drugs. Acetylcholine, morphine. You can see that they all bind to certain receptors within the body. When we do our autonomic nervous system's pharmacology, we shall get introduced to quite a number of these receptors. Okay. That takes us to ion channels. Okay. These are also proteins. However, we normally say we have receptors that are linked to an ion channel. These are referred to as ligand-gated channels, or you'll find other people or other books calling them ligand-gated receptors. But basically what really happens is that a ligand is any chemical. A ligand can be an endogenous chemical like adrenaline, histamine, or anything. Or it can even be a drug, a synthetic agent that has been formed. So a ligand-gated ion channel or ligand-gated receptors, here a drug comes or a chemical can come and bind to this receptor. And once it binds to it, it opens up the channel because it is linked to the ion channel. It opens up the channel and ions like sodium, like chloride, like potassium can flow in. So that type of receptor can be referred to as an ion channel. Sometimes they call them inotropic receptors. Sometimes they call them ligand-gated ion channel. So you can easily get to know the name when you look at it. Has several nomenclatures like ligand-gated ion channel, inotropic receptors, ligand-gated inotropic ion channels. So different books will call it different names, but as long as you get that principle that a drug comes and binds to this receptor, it opens up the channel and the ions flow in. We have also the voltage-gated channels. These open in response to changes in membrane potential, the positive or negative, the membrane potential. Or those changes that usually happen can end up opening or closing the ion channel. Those are also referred to as the voltage-gated ion channels. These ones can also work as receptor site for binding of our drug. As you can see, the drug action, direct binding to the channel protein can lead to blocking or modulating its function. And then indirect action can come via a G protein coupled receptor or via G protein and other intermediaries like maybe an increase in cyclic AMP, an increase in protein kinase C, and others, as we shall be seeing when it comes to the signaling mechanisms that we shall be seeing later. Let me hope that is clear. Please make sure you switch off all your microphones such that we can listen. We can listen very well. Unless if you have a question. If you have a question, you can interrupt. But if you don't have, just keep your microphone off. There are examples of drugs acting on these ion channels. So there are several examples of drugs that that will act on these ion channels. Drugs like lidocaine and quite a number of local anesthetic agents tend to block voltage-gated sodium channels. Quite a number of these local anesthetics, almost all of them. Actually, local anesthetic agents, their modes of action is basically through the sodium ion channels. They tend to block the inactivated form of the sodium ion channel. So that is one example. There are so many because local anesthetics, we have, you haven't only heard about lidocaine. Should be knowing other local anesthetics like bupivacaine, procaine, even cocaine is a local anesthetic agent, liginocaine, and quite a number of other local anesthetic agents. They all use these voltage-gated sodium channels. We can see drugs like nifedipine, amlodipine, and others. We shall see them at a later stage when we do systemic pharmacology, but these ones tend to bind to the L-type calcium channels, the L-type calcium channels. There are other types of calcium channels like the T-type calcium channels where other drugs bind. T-type calcium channels are usually found in the CNS, in the brain mainly, but these L-types can be found elsewhere in the body. So drugs like nifedipine and other dihydro or pyridines tend to use these types of channels. Okay, so these can also. That's why I told you that we use. You'll find quite a number of books talking about these T-type ion channels as receptors, or the receptors where drugs like amlodipine, nifedipine, felodipine work. So we can still call them receptors, but they are just proteins that are that form ion channels, and drugs usually bind to a certain site on them and it opens up the channel. Then we also have the GABA receptor. GABA is a chloride channel. GABA is a chloride channel. The GABA receptors, what usually happen is that the drug comes and binds to GABA, and then it opens up GABA. It is pentameric. It has the 5 subunits. As we shall see some of the images, there are some few images that are there. And still during your reading, you might land on them. So when you look at this GABA receptor, it is pentameric in structure. I don't know whether I have a structure of GABA around here. Yes. That structure you see in a corner there is a GABA receptor. I just wanted you to get a feel of when we talk about GABA, what we are meaning. So it is pentameric. You can see there are 5 of them. There are 2 yellows, blue, two blues, and 1 red. So that's why we say it has 5 subunits. It usually has 5 subunits. But in the middle of it, when it opens up a channel and chloride passes through and chloride enters. So that is how the structure of a GABA looks like. Okay? The GABA receptor looks like. There are quite a number of drugs that bind to this receptor and modulate it. We know drugs which we call major tranquilizers. We know drugs we normally call minor tranquilizers. The minor tranquilizers are the sedatives, hypnotics, and anxiolytic agents like diazepam, midazolam, and other drugs that are sedatives and hypnotics. So those ones bind to GABA and open the channel. Though even in our body we have a chemical called gamma aminobutyric acid. Gamma aminobutyric acid, which is basically the GABA. It is the one we abbreviate as GABA. Gamma aminobutyric acid, when it binds to that receptor, the GABA receptor, it opens it. So we have an endogenous compound that also opens it. And we also make drugs that come and open this receptor, and but it is an ion channel. It's a receptor that is in form of an ion channel. Then the ATP-sensitive potassium channels. Yes, ATP-sensitive potassium channels. These are very important when it comes to drugs, especially the sulfonylureas, which we normally use in management of diabetes mellitus. They tend to close these ATP-sensitive potassium channels and eventually make insulin to be released at one time, as we shall see later on when it comes to systemic pharmacology. So basically, those are just a few of the examples we can talk about. At least if you can remember 2 or 3 of them, that would be good as far as pharmacodynamics is concerned. And before actually we continue, and before I forget, I want to tell you that next week we shall have an assessment, and during that assessment, the things we are going to talk about today, or the mechanisms, will have to come. Yes, you make sure when you are doing your reading, just make sure you get to understand these mechanisms we are talking about very, very well. Of course, we shall also, it is going to be typical, the paper will be more of objectives. I don't want the structured questions at the initial stages. The structured will come in later, but we shall have more of the objective type. So make sure that you get to understand the PK, absorption, distribution, metabolism, and elimination, and also this these mechanisms I'm also talking about today. So try to be very attentive as well when we are discussing this. And that takes us to the enzymes. The enzymes can also be receptor types. Okay. Enzymes can also work as receptors. Drugs often act as enzyme inhibitors, competitive and non-competitive. We have quite a number of drugs that end up inhibiting this enzyme, acetylcholinesterase. There are drugs that tend to inhibit cyclooxygenase. You've seen the cyclooxygenase are usually irreversible and non-competitive, yet acetylcholinesterases, they tend to be competitive. So enzymes can also be used. These are just images to make you appreciate the enzyme activity. Then we also have carrier molecules, especially the ones we call transporters. These tend to transport polar ions and small organic molecules across membranes. These ones can also be used as receptor targets for our drugs. Okay, they can also be used as sites for our drug. Take an example of glucose and amino acid transporters. Take an example of iron and organic molecule transporters. We have neurotransmitter transporters and others. So these can also be targets. We also have amine transporters. These tend to be distinct from receptors because for them they belong to a separate structure family of carrier proteins, and they tend to have specific recognition sites for their substrates. We have many of these ones. Examples include the tricyclic antidepressants, the way they work. We have cocaine drugs that tend to block dopamine and norepinephrine, as well as serotonin reuptake. They are also targeting transporters of amines. Drugs like omeprazole, which also tend to inhibit this ATPase proton pump. Then drugs like the cardiac glycosides also work on the sodium potassium ATPase pump. So you can see these ones also target transporters. And we have also other examples of carrier molecules which you should read and appreciate as well. So that takes us to the specific types of receptors which we are talking about. We are more emphasizing the protein targets. What we've been talking about are protein targets, but you'll find those protein targets, the words being interchanged with the receptors, much as we are talking ligand-gated ion channels. You'll find some books calling them ligand-gated ion or inotropic receptors. Okay. But when it comes to specificity, when we are talking about the specific types of receptors, then this is where where this is the proper classification which you need to really understand. Though there will always be a mix with the proteins targets which we've talked about, because I told you receptors are proteins. So most of the books will always interchange these words. But what for you need to understand, you need to understand how they work. You are going to see that we are basically talking about the same thing we've been talking about, the proteins there, the protein targets, because receptors are protein in nature. And it is basically the same thing we've been talking about, only that we are going to go too much here in details. And perhaps we can also talk about the signaling. When it comes to this, we shall definitely talk about the signaling mechanism. When it comes to signaling, signaling shouldn't scare people. You know, when people hear signaling, they think it is just too complex. It is not complex. Signaling is basically understanding what really happens when a drug binds to a receptor. What happens, because we know that a drug comes and binds to a receptor, but what chemical changes are going to happen after that binding, after they've come together, making that complex? What other changes are going to happen inside there? Those are the signaling mechanisms which we shall be talking about. I made a few slides of signaling to, of course, here I've discussed it, but there are other slides of signaling which you will look at, and they are a bit simplified. You can look at it and appreciate also a signaling. This is basically the dynamics we are talking about, mechanisms of drug action we are talking about here. So receptors differ in structure and signaling mechanism and the speed of response. And there are mainly 4 types of receptors here. As you can see, we are looking at ligand-gated ion channels or inotropic type of receptors. The other side, we are talking them as proteins, and now we are referring to them as receptors. So that's why I was trying to emphasize that take receptors as proteins, that where drugs are going to bind, and we have effects. So we have ligand-gated ion channels, we have G protein coupled receptors, and we also have kinase-linked receptors, and then nuclear receptors. Those are the major 4. Okay. Ligand-gated ion channels, we've talked about them there when we are discussing proteins. We are saying here, a ligand comes and binds to it, and then it opens up the channels. The channel, once the channel opens, ions enter. They can be chloride ions, they can be sodium ions, they can be potassium ions, name it. And when they enter, of course, they make the membrane inside either more depolarized or hyperpolarized, or depending on how, depending on their function. So I'll give an example of the negatively charged ion like chloride. Once chloride enters, once the channel opens and chloride enters, it will make the neurons hyperpolarized, and it makes it very hard for the action potential to be fired in that neuron. That is how most of these drugs, which we call or, or, or the antidepressants, work. Drugs which we call sedatives, hypnotics, and anxiolytic agents. That is how they end up opening a GABA channel, which is usually chloride, which lets in chloride, and chloride is negatively charged, and then it hyperpolarizes the membrane. So the firing becomes a problem of the action potential. The action potential cannot be initiated there because of the hyperpolarization of the membrane that usually happens. These are ligand-gated channels. That is just one example. But there is also sodium, where you saw lidocaine, lignocaine, those local anesthetics, which end up opening the sodium channels. Yes. Then we have the G protein coupled receptors. These ones, their effect, they are mediators like catecholamines, peptides. These ones also operate in seconds. Remember, the first ones operate in milliseconds. They are very fast. Their transmissions are very sharp. They are very fast. These ones, the transmissions are not so fast, but they still do the work. The G protein coupled receptors. We normally abbreviate them as GPCR. G protein coupled receptors. These ones usually attach themselves to a G protein, to a G protein. And the signaling at the G protein coupled receptors, we shall appreciate it also when we come to it. Then we also have what we call the kinase linked receptors. These ones are usually peptide hormones, growth factors, and others. They take a longer time compared to the G protein coupled receptors in terms of operating time. Then we also have the nuclear receptors. Sometimes they call them intracellular receptors. The nuclear receptors, you might think that they are all in the nucleus. Some of them are in the cytosol of the cell. They are not directly in the nucleus. So they bind the ligand in the cytosol. After binding, they move to the nucleus, some of them. Some of them go and bind they have their binding sites in the nucleus on usually the DNA. But others, like what I've told you, their binding is usually in the cytosol, and then after they bind to the drug, the receptor and the drug complex moves to the nucleus and binds to the DNA. This is how the steroid hormones work. For them, they don't go straight to the DNA in the nucleus and bind. They first bind in the cytosol and move. But there are other drugs that go direct and bind to the DNA. So these we were just talking about the types, highlighting the types, and these are some of the specific details of the types we've been talking about. However, when you look at it, some of them have mentioned quite a number of the details during the initial stages there. So when we go back to the regard type, or
Excuse me,
regard-gated ion, yes.
Doctor, on the ligand-gated ion channels, do they only the firing or they can also initiate it as well?
Come again? What do you mean?
Like as you were explaining how the ligand-gated ion channels work, you said that like they can either make they can either lead to hyperpolarization or something less than that. So I'm wondering, do they
It
only
depends. It depends. I've understood what you're trying to say. It really depends on the ion that is entering, whether it is positively charged or whether it is negatively charged. The hyperpolarization I was talking about, I was referring to the chloride ions, which are negatively charged. But with others, they cause depolarization of the membranes. Those that are usually positive, like the sodium channels. I mean the sodium ions. You get it? So
yes?
it really depends on which ion has been allowed to enter. And these receptors are specific. The one that allows chloride does not allow potassium. The one that allows sodium does not allow does not allow chloride. That's why they are specific. You can see some of the examples here that have been given. There's a glutamate, which glutamate receptor. So we normally call them NMDA receptor. NMDA receptor. The name is very long. You can check and find out what NMDA means. But this is a receptor that usually binds aspartate. Aspartate, we produce it as an endogenous compound. And glutamate. Glutamate is also an endogenous compound which we normally produce in our body. And when you bind to this receptor, it is usually excitatory. We see depolarization happening, and we normally see the receptor itself is excitatory. Why is it excitatory? It allows in calcium. When it opens, it's an ion channel. It's an inotropic receptor. It's an ion channel. It looks more like the way you see that GABA receptor is. So it opens, it allows, once it opens, the channel allows in calcium. Calcium flows in, yes? And we see depolarization. Calcium is positively charged, and we are seeing depolarization happening. So yet when it comes to GABA, we are seeing what? We are seeing the ion that is flowing in after the opening of these GABA channels. The ion that flows in is chloride. chloride, which is negatively charged. So in most cases, it really depends on which ion and which receptor is getting stimulated. So that is about the chloride channels. I mean the inotropic receptors. Nicotine acetylcholine receptor is also
Excuse me, doctor.
inotropic. Yes.
Good morning, doctor.
Good
In
morning.
pharmacokinetics, you said that if a drug combines with a protein, it makes the drug less reactive. But then in pharmacodynamics, you've said that if a drug binds to a receptor, of course, it will bring about some changes depending. So does it mean that drug binding to a receptor in pharmacokinetics is different from the explanation that is in pharmacodynamics?
Okay. Oh. Okay, that is a good one. When it comes to pharmacokinetics, the binding we are talking about, you see, when a drug binds to a receptor, there are different activities or effects that are going to happen when there is a drug receptor binding. For example, when I was talking about the binding of the protein, the proteins in blood during pharmacokinetics, we were just referring to the proteins that are we are just referring to the proteins that are usually in blood. However, those proteins in blood are not receptors. They are just proteins. Yes, we are not seeing any receptor activity when that binding takes place. We have so many different proteins and they have different functions. So by saying a receptor is a protein in nature, it doesn't take away the other fact that it is a receptor and it functions as a receptor. Only that it is made of protein. So the other protein they are also proteins, but they are not functioning as receptors. They are just functioning as sites where drugs are going to bind. And when they bind, they just make that complex. So the effects we are seeing there during that binding, the pharmacokinetic binding during transportation in blood, is going to be. That's why, if you remember very well, when I was trying to explain actually in kinetics, I said a drug gets absorbed. Once it gets absorbed, it lands into blood. Now, when a drug lands in blood, in plasma, what do we see? We find some proteins circulating in plasma. A lot of proteins, albumin and the glycoproteins. But depending on the pH of the drug that has entered, whether basic or alkaline, Some basic drugs usually, I think they are the ones that love binding to albumin, and then acidic drugs love binding to protein. But when I mean to glycoprotein. But when they do the binding, they form a complex there, which holds them. However, remember when I was explaining, I said that drug that has gotten bound to a protein, that which is either albumin or we are not seeing any other reaction other than the binding and holding it there. That is basically what really happens during distribution in pharmacokinetics. It just holds it. And I told you that, however, some drugs are not going to get bound. They are going to remain free. And it is the free drug that usually binds to the receptor. Remember, I was always talking about the active drug and the one that was not active, or the free drug and the bound drug. The bound drug is this one that was binding to the receptor, but activity wasn't coming from this that is binding to the receptor. Activity was coming from the free drug. I mean, not to the receptor, to the protein, the glycoprotein or the albumin. Activity was coming from the drug that was free, that was going and binding to the receptor, the free drug. Let me hope that was clear. All that
Yes.
is now clear.
Yes, thank you, doctor.
Yes. So it binds to, the free drug binds to the receptor. And that is when we start seeing this interaction we are now talking about, the dynamic interaction, the pharmacodynamic interaction we are currently talking about, comes from that. But we didn't go further than that in kinetics. In kinetics, we just talked about the binding to the glycoprotein to make that complex, which makes the drug inactive. However, we said the active portion goes and binds to the receptor. And we see activity from there, but we did not further talk about that activity because that is now the receptor, drug receptor binding. The drug receptor binding is now the one we are talking about, which we stopped the other side. We just said there is activity, a free drug goes and binds to a receptor. Now we've entered inside what happens in a receptor when that free drug now binds to a receptor. Now that is dynamics. It's no longer kinetics. Let me hope that is clear. So basically, the other type of receptor are these nicotinic acetylcholine type of receptors. And of course, these ones have also different subunits, have GABA, beta, gamma, even delta subunits, these nicotinic acetylcholine receptors. Okay. You will excuse me because I'm at home. Some people will make noise in the background. I just hope it doesn't. A lot of it doesn't reach you there. But you will excuse me for that if anything comes that side. So the ligand binding also happens with this type of receptor, and we see some ions, especially sodium, getting released. So these are the examples which you can give here: the nicotinic acetylcholine receptor, the GABA receptor, the glutamate receptor. We don't need a lot of examples, but as long as you can easily understand one and explain it very well, whether you can explain GABA, whether you can explain the nicotinic, whether you can explain glutamate, that would be good enough for me. It is all understanding that we need to get here. We need to get the principles. Okay. This is the nicotinic type of receptor we are talking about. It also has an ion channel, as you can see the pore there. And once acetylcholine binds, it opens up the pore. So basically you need to remember that. Then that takes us to the G protein coupled receptors. Sometimes the G protein coupled receptors are also referred to as metabotropic type of receptors. Unlike the other ones, the ligand, the ion channels which we've just talked about, the ligand-gated ion channels, or inotropic. These metabotropic type of receptors have 7 transmembrane rings. There are 7 transmembrane rings. The other ones, we are talking about a pentameric structure, meaning that penta is 5. We are here seeing 7. So whenever you hear anything like 7 transmembrane rings, just know we are talking about a G protein coupled receptor, or we are talking about a metabotropic receptor. These receptors are usually linked to an intracellular effector system through a G protein. That's why they call them G protein coupled receptors. A G protein is coupled to a receptor. A G protein is attached to a receptor. Let me hope this is clear. They form the largest receptor subfamily. By forming the largest receptor subfamily, it means that quite a number of drugs interact with these receptors, these G protein coupled receptors. They form the largest family and mediate the actions of many hormones and neurotransmitters. Some of the examples of these type of receptors are the muscarinic acetylcholine receptors, adrenoceptors, chemokinins, and others. They are all G protein coupled type of receptors. They can be differentiated into like 3 major groups. We have the GS, the GQ, and the GI. As you can see, they are all coupled to a G protein. You can see this is the G protein. There are 7 transmembrane rings. You can count them, 7, 7, and these are 7. But GS, GI, and GQ have some slight differences in them. when you look at a GS coupled type of receptor, the effector protein that it attaches to is adenyl enzyme. Yet for GQ coupled type of receptor, the receptor protein is a phospholipase C enzyme. And then for GI coupled type of receptor, the receptor protein is the same as the one of GS. However, for this one usually increases cyclic AMP, and this one usually decreases cyclic AMP. Cyclic AMP is cyclic adenylase monophosphate, AMP. However, for phospholipase C, it usually leads to other messengers. These are messengers, secondary messengers, like diacylglycerol and IP3. Diacylglycerol and IP3, which is for GQ coupled type of receptors. The major differences between GQ and GS and GI is around here. And there are quite a number of objective questions that come from here that can end up confusing students. People can ask you about phospholipase C, and they ask you the secondary messengers that are usually produced. Or they can just talk about the G protein coupled receptors and ask the secondary messenger that are produced, which is basically diacylglycerol and IP3. Just put DAG and IP3 as their secondary messengers. Yet here, if I'm to ask for the secondary messenger, I expect you to talk about cyclic AMP as the secondary messenger. In most cases, these come as objectives, and we just put them in objective. We put cyclic AMP, diacylglycerol, we put IP3, and we can even put protein kinase C. And we want you to either pick this or you pick this. Let me hope this is clear. So when you are
Dr.
doing
Sunlight, what is a secondary
Doctor.
messenger?
May you please pardon me on the secondary messenger for phospholipase C? Thank you.
the secondary messengers for phospholipase C are diacylglycerol, which is DAG. We normally abbreviate it as DAG. So whenever you find it in an objective written, we normally don't write their full names in most cases. We just put what? Because these are standard. They are standard name. CAMP is standard, but only when you are writing it, you just put a small c, and then these are capital. This small c is basically cyclic, and then AMP. So these are standard abbreviations, and you will always find them in a paper as standard. The secondary messenger for phospholipase C, who can mention them?
Yes, doctor, I'm here.
Yes.
Yeah, the secondary messenger for phospholipase C are two. We have DAG and IP3. Thank you.
Okay, you are right, 100% right. So the secondary messenger, just look at this side. We have a neurotransmitter, we have an effector protein, we have a secondary messenger, and the later effectors. So you
Doctor,
look at
maybe some light up. What does a secondary messenger do?
a secondary messenger is is a chemical that when it is released, it also helps release of other enzymes or proteins that are going to be used at the effector cell to stimulate a physiological, or in this case, if it's a drug, it will be a pharmacological or effect. So secondary like as you can see here, here the effector protein. We are looking at a cascade of reactions happening that in some receptors, I'll give an example of the previous receptor we've been talking about, the inotropic ion channels, or the ion channels we've been talking about. For them, they don't have these secondary messengers. There are not so many steps you are going to go through to reach the final response, the effect you are looking for. However, with this G protein coupled receptor, there are quite a number of other steps which involve other messengers. These are all messengers, but the secondary messengers, I would be saying, is another level of, I don't know how best I can explain it, because it's a cascade of reaction. You are moving from this reaction to another reaction, from this reaction to another reaction. So I think I failed to get a better word to put it.
Excuse me, doctor.
Yes.
Maybe you good morning.
Yes, good morning.
I would request maybe you add on the front. I'm struggling to read, especially in the G proteins, the receptors, the secondary messengers, those words. If you can try to add on the front.
How am I going to add the font? Hey, wait.
Kindly just zoom in.
Let me see. That one. Yes?
Yeah, there it's
that
okay.
That is better.
Yes,
That
doctor, it is okay.
Okay, but we were still talking about the secondary messenger. These are more kind of reactions that are going to take place. That as we said, I said with the G protein coupled receptors, we normally have a cascade of reaction taking place. And one of them, of course, they take place at different levels. That a G protein, the G protein first initiates these reactions. An enzyme comes and attaches to it, or an enzyme, that enzyme, once the enzyme comes and attaches to it, it stimulates other reactions, enzymatic reactions. And those enzymatic reactions that are stimulated are usually referred to as the secondary messengers. And the secondary messengers are specific to the different pathway we are following, whether a G2 pathway or a GI pathway or a GS pathway. So for specifically G2 coupled receptors, we see the messengers, the other messengers that are released within that cascade of reaction are basically DAG and IP3. Yet for GS, we are seeing cyclic AMP, and GI, we are seeing CAMP, which is basically cyclic AMP. And I've tried to explain the difference between a GI and a GS. GI is usually inhibitory in nature, and GS is usually stimulatory in nature when it is released. So for GI, you are when we shall see a decrease in cyclic AMP here at the very end. We are seeing a decrease in cyclic AMP, this brownish reaction you are seeing cascade. This will be a decrease in cyclic AMP. Yet here at a GS, we are going to see an increase in cyclic AMP. I don't know whether my cursor is being seen very well.
It is clear, Doctor.
Yes, we are able to see.
The cursor.
Yes, please.
Okay, so we are going to see an increase in cyclic AMP, yet this side we are seeing a decrease in cyclic AMP, and those can lead to different reaction. As you can see, much as it is still phosphoprotein kinase A that is released here, because for GS it is an increase in protein kinase A, we shall see an increase in protein phosphorylation. Yet on this GI protein coupled receptor, because we are going to see a decrease in cyclic AMP, we shall see a decrease in protein kinase A, which will eventually lead to a decrease in phosphorylation of protein. These proteins we are talking about can be enzyme. Those are the end products of the whole reactions, which are going to bring about the effect we are looking at. We can release a certain protein, or we can release an amino acid, or we can release a certain enzyme that will bring phosphorylation. Okay, we can phosphorylate these proteins, and the proteins or amino acids or enzymes that are going to bring about the effector effect, which we are targeting at the end of it, which might be either contraction of the muscle or relaxation because a certain protein has been released, or anything, any physiological effect can come as a result of this, depending on which receptor we shall be talking about. Then for G2 coupled receptors. For them, they usually lead to the release of protein kinase C. And of course, the release of protein kinase C also has its end effect. It usually leads to an increase in phosphorylation of certain amino acids and proteins and the like. And also, it also leads to activated calcium binding to certain proteins. So basically, these are the reactions that will happen. Those reactions will give different effects at the end of it all. We shall see here. You might not pick the picture very well of the effects, but when we start our systemic pharmacology, and we tell you that this is a G protein coupled receptor or G2 coupled receptor or GS coupled receptor or G coupled receptor, you will be able to see the end effect very well, because in systemic pharmacology we are looking at more of the therapeutic response that is going to happen. This basically gives us the introduction, such that when it comes to the systemic pharmacology, we can easily understand how it works. I think this can better be understood when it comes to the systemic pharmacology. However, these same principles are also discussed in biochemistry. Some of them are even discussed in physiology. So, because even the physiologists are talking about this reaction, because as I told you, endogenous compounds also bind to the same receptors and stimulate them the way we are stimulating them with drugs here. So, for example, adrenaline can bind to the same receptor, or acetylcholine, which is endogenous, can bind to the same receptor, and we see stimulation. So you find also this being taught in physiology. Let me hope I've tried to explain it, but you will get to understand it better. See, when I put it in full mode, let me first see. For me here, part of what I'm supposed to show you disappears. The slide always appears too big on my side, on my screen. Let me see if I can hide this. Hide. Okay. So the other type is the kinase-linked type of receptors. These are large and heterogeneous groups of membrane receptors that are mainly respond to protein mediators. The kinase type of receptors, they are usually heterogeneous and they are large, and they mainly respond to protein mediators. They are usually composed of an extracellular ligand binding domain, a single transmembrane helix, as well as an intracellular domain. And I don't know whether I placed an image for kinase. I'll see. If I didn't place, you will check for this kinase type of receptors. There are quite a number of examples here of drugs that use this type of receptors and the receptor subtypes. Among the receptor subtypes, we have the tyrosine kinase receptors, where insulin usually work, and certain growth factors also tend to bind to these tyrosine kinase receptors. We have the receptor serine, or they normally call them threonine type of receptors or kinases, and here also certain growth factors tend to bind to this. We also have cytokine receptors, like the genus kinases, which they normally call abbreviated JAK. These ones, drugs like erythropoietin, which we normally use at times in patients who have challenges with blood, like in those patients who cannot produce some of those blood cells, or who have some dysfunctions as far as those blood cells are concerned. This is where drugs like erythropoietin will bind to. And we also have receptor guanylase cyclase, where ANP is a arterionucleotic peptide. This one is usually released when the heart is getting stressed. The BNPs and ANPs, we have certain drugs which we shall see, like a drug called sacubitril, which we normally combine with valsartan, which is an ARB. It's a new formulation. For it binds specifically to these receptors called the guanylase cyclase receptor types, and other examples. Then that takes us to the fourth type, which are nuclear receptors. And nuclear receptors are usually intracellular receptors. They are found within the cell. They are not found on the cell surface. If you've realized, the three other types of receptors are usually found on the cell surface. We are always talking about the cell membranes, crossing the cell membrane. But these nuclear type of receptors are inside the cell. And most of them are in the nucleus. So drugs that usually bind to these receptors bind to DNA, to the DNA itself. However, as we said in our previous short discussion, we said that these drugs, there are some which do not generally just go straight and bind to DNA, but they bind to receptors within the cytosol. They enter the cell and bind to receptors within the cytosol, and then move that complex, the drug receptor complex moves, and it enters the nucleus, and it then binds to the DNA. That is what they are saying, that they translocate to the DNA afterwards and then stimulate or lead to transcription of factors. Examples of these types of receptors are steroid receptors, or drugs like steroids tend to bind to this type of receptors. That's why we normally say steroids penetrate and enter the cell. However, they enter the receptors they usually bind to are within the cytosol. And then after binding to those receptors, after making the drug receptor complex, it is that complex that goes and binds to the DNA within the nucleus. And quite a number of these drugs, the glucocorticoids, the steroids, the mineralocorticoids, thyroid hormone, and others tend to bind to those receptors. There is a drug receptor concept which you need to understand. However, what I want you to understand here is mainly what we've been discussing in our previous discussion, in our few previous slides. That what really happens to a drug what really happens when a drug binds to a receptor. Of course, there are certain scientists like John Langley in 1876 who studied what really happens using drugs like atropine and pilocarpine. And also another scientist in 1909 called Paul Ehrlich studied still these receptors and proposed that drugs exert therapeutic effects only if they possess the right affinity for the receptor. Only if they can bind to the receptor and stimulate it. That is the affinity they are talking about. He defined the receptor as that combining a group of the protoplasmic molecule to which the introduced group is anchored. The protoplasmic molecule to which the introduced drug anchors.
Excuse me, doctor.
Yes.
Yes, well done. Thank you.
Yes.
I have a question. During anatomy lectures,
Yeah.
Dr.
Yeah.
Arona mentioned that there was a doctor who had problem with his dental issues. He had dental issues, and they went to do some surgery. Then there was a lot during the surgery process. There was a lot of salivation. There was a lot of saliva excretion, and the other doctor had to pick a tablet and dropped into his mouth. Up to now, the person is losing saliva, doesn't produce any saliva. What could be that drug? Thank you.
What could be the drug?
Yes.
That caused
Saliva to disappear.
the
Yes.
glands to disappear.
The glands to fail to excrete any more saliva.
I can't tell which drug it was. I can't tell which drug it was.
Okay.
The effect. May I think sometimes it's not actually even the drug itself that caused the problem. It could have been even the combination of the different drugs that the person was or the doctor was using at that specific time that could have reacted and maybe blocked or some of the receptors, and it is not specifically this drug the person, the doctor used at that particular moment. Because that case looks to be a bit unique. Otherwise, yeah, you can't tell which exact drug that caused the problem.
It's okay, thank you.
But we can always dig around it and find out what really happens, especially if you've been given enough information, which drugs he was using, and there you can easily tease out and say, because of the mode of action of this drug, this could have happened. But that one is so plain, you can't tell.
Yes, okay. Thank you so much.
You're welcome. Then receptors are specialized target macromolecules located on the surface. However, some of them, as we saw that steroid receptors are not on the surface, they are within, they are inside. So let me hope this is clear. They usually bind drugs and trigger biochemical and physiological changes that end up altering the cellular and organ function. So the effects we are talking about come as a result of these physiological, physiochemical and biochemical changes. From a numerical point, proteins are the most important class of drug receptors. As we said, most receptors we are talking about are protein in nature. And they include hormones and others. Basically, this concept is what we've been talking about previously. Drug receptor interactions, of course, when drug interacts with a receptor, it forms a bond. And those bonds can be either ionic, hydrogen bonds, they can be weak, van der Waals forces, hydrophobic interactions, they can even be covalent bonds, which are really strong bonds. That's why you see some of these reactions are sometimes irreversible, some are irreversible. Most drug receptor interactions include multiple types of non-covalent bonds. The ones like we've been talking about, which are weak. Covalent bonding usually results in prolonged drug actions, while the high affinity non-covalent interactions may have essentially irreversible or actions. There's this drug receptor interaction that produces the drug receptor complex. You can leave out the rest and just appreciate that when we combine a drug and a receptor, we always make that drug receptor complex. Of course, we can use this in modeling and finding out the strength of the interaction, but this you don't have to go there. In general, drug receptor interactions occurs in two steps. It occurs by binding to the receptor, which gives us the affinity, and then generating a response, which usually give us the intrinsic activity. So we shall, whenever a drug binds to a receptor, we always see affinity, which is basically the binding. And there is also the intrinsic activity, which is the biological response that usually happens. That takes us to drugs which we call agonists. Because an agonist binds to a receptor, we always say that it has affinity. However, because there is an effect that comes, a response that comes after an agonist has gotten bound to a receptor, we always say an agonist has an intrinsic activity. So an agonist has both affinity and intrinsic activity. However, when it comes to an antagonist, when an antagonist binds to a receptor, we always see affinity. So it comes and attaches to the receptor. That is the affinity we are seeing. However, we don't see any response. We don't see biological response. So it binds to a receptor, but it cannot stimulate it like an agonist. So we normally say an antagonist doesn't have intrinsic activity. It has affinity with no intrinsic activity. Yet an agonist has affinity and intrinsic activity. So those are basically the two steps that are very crucial as far as drug receptor interaction is concerned. The binding, which we always take as affinity, and then the response that is generated, which is the intrinsic activity. Agonists have binding, both affinity and intrinsic activity. However, antagonists can bind, but we don't see any intrinsic activity. So that takes us to potency and efficacy. Potency refers to the amount of the drug required to produce a given effect. A drug is considered to be potent if it produces a significant effect at a low dose. Let me hope this is clear. We consider drug to be potent if it produces a significant effect at a minimum dose, a minimal dose. So, or when we give two drugs, one can be referred to as more potent than the other drug, because it is producing a significant effect at a low dose. This usually manifests very well when we are seeing, when we draw the dose response curves. And I'm very sure when you do that tutorial we gave during this week, you will be in position to see these curves. Of course, I didn't put them there purposely because I wanted you to tease them out, but the statements will not change. A drug is considered to be potent if it produces a significant response at a low dose. And two drugs, one can be more potent than the other. If one gives us a response, a maximum response or a significant response at a lower dose compared to the other. If I have amlodipine and felodipine, or if I have, I'll use the one that are common, amlodipine and nifedipine. I can say amlodipine is more potent than nifedipine. If amlodipine produces a significant response, the response I'm looking for, in a shorter time compared to nifedipine. They are all calcium channel blockers. They bind to the same receptor, but one is more potent than the other because it produces an effect, a response, a significant response at an early or at a smaller dose compared to the other. Whereas efficacy refers to the maximum. So potency, what you need to remember here, potency is not the same as efficacy. Yes? Efficacy refers to the maximum or the peak response a drug can produce, regardless of the dose. So drugs can have the same efficacy, but different potencies. One can be more potent, but they are all effective. They all produce the maximum response, but one takes longer to produce that maximum response. So you always find these curves drawn in two curves, and they are parallel to each other. One is, they are parallel to each other, showing that one achieves the potency much more earlier than the other. I told you I didn't put these curves purposely because I wanted you to tease them out very well. Okay. So you need to remember that. The intensity of drug response, make sure you read about it. It's still about the theory and their importance, the importance of this concept also, read about it. I just want us to understand the agonist and the antagonist. I know they are going to, it is going also to come out when you are doing your tutorial. The week, I think it will be next week. This is also going to come out very clearly, the agonist and antagonist. So I did not put the curves there because you won't do anything if you see the curves. But we need to understand these important terms. What is an agonist? What is an antagonist? An agonist is a drug hormone or a neurotransmitter that binds to a specific receptor, and it activates it and initiates a response. I told you it has affinity and intrinsic activity. This is an agonist. An example is acetylcholine on the acetylcholine receptors. Then we also have an antagonist as a drug that binds to the receptor but does not activate it. Instead, it prevents the action of the agonist by blocking access. And I told you an antagonist has affinity, it binds to the receptor, but it doesn't usually have intrinsic activity on that receptor. That's why we are saying antagonist has no intrinsic activity of its own. And the examples of antagonists are drugs like atropine, which bind to a muscarinic receptor and blocks it. Naloxone, which binds to an opioid receptor and blocks it. So it has the affinity for the receptor, but doesn't have the intrinsic activity. We also have drugs
Doctor,
which
if I
we
may
call...
ask, does it mean that most antidotes are antagonists?
Not really, but some are antagonizing the receptors. They just come and block the site where the agonist will bind. And they occupy that site, which means that they have affinity for the site, so they block it, and they don't have an intrinsic activity. However, not all of them work in a similar manner. Not all antidotes work like that. Some antidotes work by just neutralizing the other drugs. Some antidotes work by just blocking the absorption. They are quite, it depends on which antidote you are talking about. Like here, naloxone is an antidote for opioids, just in case of toxicity. And even atropine can be used as an antidote when it comes to toxicity with drugs like acetylcholinesterase, the acetylcholinesterase inhibitors. We can use it as an antidote. But for them, they are working at the site. But there are certain drugs I've told you, like charcoal, which does not necessarily have to be working at the receptor level, and quite a number of others, as we shall be seeing. We wanted also to talk about the partial agonist, and we said a partial agonist is a drug. This is a drug that binds to a receptor and activates it, but produces a weak or suboptimal response compared to a full agonist. So it doesn't give us a maximum response like a full agonist. For it, it produces a suboptimal response, but the response is there. So we can call it a suboptimal response. Someone might wonder why should you go ahead and prescribe a partial agonist, and yet they are full agonists. This is very important to understand. partial agonists are drugs that are really important in some conditions. There are certain conditions where partial agonists are used because of the way they work. I'll give an example that if you give a partial agonist and there is a full agonist present, a partial agonist will work as an antagonist. You remember, try to remember this, that a partial agonist in presence of a full agonist, a partial agonist works as an antagonist. So what really happens is that it works as an antagonist, but it will not block the receptor to the level of an antagonist, because an antagonist will have no effect at all. It has zero effect. You get it. But a partial agonist can block the receptor. It competes with the agonist for the receptors because they are all binding to the same receptors. They compete with the agonist for the receptors, and it blocks some of the receptors. So even if the full agonist is present, it will not give the maximum response, because some of the receptors have been occupied by the partial agonist. So it reduces the activity for the partial, for the full agonist. That's why we say in presence of a full agonist, they work as antagonist. Let me hope this is clear. Examples of partial agonists, we have drugs like aripiprazole, which is a typical antipsychotic, and it works as a partial agonist on dopamine receptors. Why do we say it works as a partial agonist? Because dopamine is a full agonist. So the body, in your body or in your CNS, you already have dopamine circulating as a full agonist. But we want to stop it from, to reduce its activity, the dopaminergic activity. So we give a drug that is not going to fully bind to all dopamine receptors. If I give aripiprazole is going to enter and start competing with dopamine. So it will displace some of the dopamine from the receptor. So the effect of dopamine is going to go down. Yet aripiprazole cannot give us a full response. It has occupied the receptor, but it can't give us a full response. So we balance, instead of the too much activity which was being brought in by dopamine, the activity is going to be reduced. That's how partial agonists work. There are quite a number of drugs which we give as partial agonists, and they can be used. Another example, in management of breast cancer, we still use a lot of drugs. I'll give an example of tamoxifen. Tamoxifen is given in management of breast cancer. But when you look at how breast cancer happens, it is as a result of too much release of estrogen. Estrogen is getting released a lot, and it is stimulating those estrogen receptors. So the breast cancer patient, the cancer continues getting metastasized. simply because there's a continuous release of estrogen. And we know estrogen does a lot of things. Physiologically, it has a lot of physiological functions in our body, in women. So we cannot just stop estrogen from getting released. But it is the mother problem. It is the one causing the problem. So what do? We get a drug called tamoxifen, which has structural similarities to estrogen. And when we give tamoxifen, because tamoxifen is a partial agonist of the estrogen receptors, it goes and binds to the receptor and starts competing with estrogen for the receptor. So less estrogen has chance to bind to the receptor because they are competing with the drug, with this drug tamoxifen. So estrogen occupies fewer receptors. So the effects of estrogen are going to slightly go down. Let me hope this is clear. That is how partial agonists work. Then we have inverse agonist. A drug that produces an effect opposite to that of an agonist is what we call the inverse agonist. Unlike competitive antagonists, these are not antagonists. The inverse agonists, that's why we are saying unlike competitive antagonists, which block the agonists without intrinsic activity. Inverse agonists usually have some kind of activity that is in an opposite manner. It has an opposite response. When you look at this example of benzodiazepam, is an agonist on a GABA receptor, and it causes sedation and other anxiolysis, muscle relaxation, name it. However, an inverse agonist like beta carbolines, these ones usually tend to bind to the same receptor but cause stimulation, anxiety, increased muscle tone, and convulsions, which are opposite to what the benzos do. They are giving an effect which is opposite to what the other drug is giving, what an agonist of that receptor is giving. But they are not antagonists. So we also have drugs which we call mixed.
Excuse me.
Yes.
So do the inverse agonists also bind on the same receptors as the agonist? Do they have the same binding receptors or they have a different one?
Same.
Receptor. A drug, we also have mixed agonists. These, I think, by the way, all these are supposed to be covered in a tutorial, some of the tutorial questions. So I'm very sure during your tutorials, you try to read them again, such that you discuss it such that you get to understand it better. A mixed agonist, a drug that acts as an agonist at one receptor subtype and as an antagonist at another receptor subtype. So it can work on this receptor as an agonist and on another receptor as an antagonist, and we normally call them mixed antagonists, agonist-antagonist. Example, we have some opioids that have such activity. So this is what I wanted to mechanisms of signal transduction. I think this slide was meant to be here. I wanted this picture to come before here. So after mixed, you come to the picture. That is what I wanted, but I think during that time when I was working on them, I failed to put it in the right place, but now it's in the right place. So this is what I want you to understand. Some of those curves are showing you the full agonist, the partial agonist, a weak agonist. The antagonist has been missed. I didn't realize it, but the antagonist is supposed to be here. The antagonist is supposed to be there. I wish I could draw it now, but I'll give you the slides when I just copied this from the internet. I didn't realize that antagonist was not put. But the full agonist at least is there, the partial agonist, the inverse, and the antagonist. And these are the images are basically talking about full agonist, antagonist, and an inverse agonist. So let me hope that is clear. I just want us to give ourselves a break of 15 minutes. We give a break of 15 minutes. I don't know, we should, for purposes of not we can stay online such that we don't get the other problem we used to get last time when we go off and coming back, sharing the slides becomes another problem. Let's stop here. We rest for 15 minutes. So we shall be coming back at exactly 11:30. And then we shall continue and probably finish our presentation by maybe 1.